In this playlist of oriented history taking and case studies, the system we will discuss is the cardiovascular system. We will complete the general history. Now we will start the specific history. In the cardiovascular system, we will discuss these few things. First, we have cardiovascular system related chest pain, dyspnea if there is shortness of breath, palpitation, awareness of heartbeat, syncope means faintness or dizziness, swelling in the leg or edema or any kind of claudication. It's of neuromuscular cause. These are the six things we will discuss. First, we have chest pain. This is part 2, specific history and differential diagnosis. First, ask the patient about the site of a pain. If there is pain in the central, latissimus and the epigastric, ask the patient about the site of the pain. Onset if it is gradual or sudden, duration short or long, and its character is most important. If there is burning pain, tearing pain, sharp, heavy, and the severity of the pain, if it interfere with the daily activities, sleeping, shooting. Levine sign. What is the Levine sign? When the patient with an anginal pain is asked to localize the sensation, then what will he do? He or she will typically place their hand over the sternum, sometimes with the clenched fist. This is the Levine sign. Radiation, if the pain is radiating and move from one side to the other. What is the time, progression and frequency of the pain? Aggravating and relieving factors. If the pain increase at the rest or decrease, nitroglycerin, breathing, coughing. In case of breathing, coughing, cold, excitation, exertion, pain increase or decrease. If there is spicy food intake, pain increase, it means it's of GI tract problem. These are the signs. These are the questions we will ask in case of chest pain. We will ask about the associated symptoms, that is fever, cough, dyspnea or shortness of breath, past history, previous heart attack history, chronic bronchitis, inflammation of the bronchi, asthma if there is patient suffering from asthma, hypertension, diabetes mellitus if there is any risk factor or family history of heart attack, myocardial infarction, angina or recent death in the family, social history of the smoking. So it's all related to the cardiovascular and the angina, chest pain. Okay, some common causes of chest pain are, there is cardiac, this you can see mitral valve prolapse, pericarditis, angina. These are the cardiac causes. Lungs, it include pulmonary embolism, pulmonary infarction, pneumonia, any kind of tumor, malignancy, pneumothorax, air in the thoracic cavity, TB. And there is chest pain causes also of esophagus, esophagitis, inflammation of this esophagus, esophageal spasm, Mallory-Weiss syndrome. This is the bleeding in the upper GI tract. Some causes are mediastinal. It include malignancy, tracheitis. It means inflammation of trachea. Chest pain also have musculoskeletal system causes such as the osteoarthritis, any kind of rib fracture, costochondritis. In this condition, there is inflammation of the cartilage that attach from rib to the sternum. Cutaneous, there is cutaneous causes such as herpes zoster virus. There is aortic disease that can cause chest pain such as aortic dissection or aortic aneurysm, in which there is a bulge formation in the aorta, and this is the condition of tear. dissection, spinal causes such as prolapse, intravertebral disc. These can cause chest pain. So next we discuss the myocardial infarction. This you can see the site. We will discuss the site, onset of the pain, nature of the pain, radiation of the pain, any kind of aggravating and relieving factor in case of stable angina. These are the descriptions. In case of unstable angina, this is more severe than the stable angina. Pericarditis, aortic dissection, pleuritic pain. These you can see. These are the diseases and their description are given next. This is very simple explanation. Some note point: pain of pleurisy involves central part of diaphragm, and if is referred to the shoulder tip and the neck, since the pain fibers from this part of a diaphragm run with the phrenic nerve, while parietal pleura covering the outer part of the diaphragm is innervated through the thoracic root. The lower six of which are responsible for supply of skin area are the diaphragm wall and the back. Pleural pain is therefore frequently referred to the abdominal and the lumbar region. This you can see due to the nerve innervation. The pain is radiating. In these cases, we have an example. The condition repeatedly started gradually over few minutes as a moderately severe chest pain that was located in the center of the chest when the patient walked more than 300 meters. Each time the patient felt it as burning pain, lasted for 5 minutes, radiating to the jaw and left shoulder, associated with the mild sweating and nausea. The pain, however, soon relieved with the rest and sublingual nitroglycerate or glyceryl trinitrate. The most likely diagnosis is stable angina, in which when we take medication the pain reduce. What is the diagnosis in such a pain? Present at rest are more severe than usual pain or occur at less degree of exertion or rest. The diagnosis is unstable angina. If such a pain present at rest or it become more severe than usual pain, then this is the, if the pain at the rest or exertion, so it is the unstable, it's not be stable, so it's unstable angina. Example number 2, the condition start gradually as the severe chest pain that occurred after heavy meal last night. The pain was located in the center of the chest, squeezing in the nature, radiating to the neck and inner border of the left arm, and remember this left arm, and was accompanied by the nausea, 2 attack of vomiting, transient breathlessness. The pain experienced for the first time persisted for 30 minutes and relieved slightly by the rest. So this is the diagnosis of myocardial infarction. These are the symptoms that make the diagnosis. Example number 3, the condition started suddenly as the chest pain that was located in the center of the chest, slide to the left of the sternum, sharp in nature, catch the patient during coughing and inspiration, radiating into the neck, arm and left shoulder, severe in intensity, but varies with the movement and respiration, relieved by sitting, and interfused by laying supine. The chest pain was preceded by the low-grade fever, and also this you can see in this case have a low-grade fever for the previous 1 week and was accompanied by the nausea and awareness of the heartbeat, mean palpitation. The most commonly diagnosed is in acute pericarditis, where the pericardium inflammation occur. Next we have example number 4. The condition started very suddenly as the severe chest pain in the upper part of the chest in the center, sharp and tearing in nature, felt penetrating through to the back in the area between the scapula. Very severe in intestine, especially at the start, and relieved only when seek medical advice and injectable form of medication. The pain was associated with sweating and breathlessness. The pain was later felt in the back and migrating down with the time. So this is the diagnosis of aortic dissection where there is tear in the aorta. Next, example number 5, the condition started 2 days ago as low-grade fever, sore throat, and the dry cough. Note down the symptoms. The condition after that developed gradually as the chest pain in the left of the chest, anterior, persistent, sharp, and knife-like in nature, sometimes related to the left side of the abdomen and the back, severe in intensity, precipitated by the breathing, coughing, and movement of the trunk, and relieved by the laying on the left side. The chest pain was associated with the cough and breathlessness. The most likely diagnosis is pleural pain from inflammation of parietal furrow and from pleurisy, pneumonia, pulmonary infarction, or neoplasm. Example number 6, we have these are the cases. Their symptoms lead to their diagnosis. The condition started gradually over the preceding 1 month as occasional attack of chest pain that is located in the center, burning in nature, sometimes radiating in the back from the mild to severe, precipitated by the large meals and bending or laying down, and relieved by the antacid medications. The chest pain was associated with regurgitation, means flowing back of the blood, no sweating or breathlessness. This is the first time the patient felt such a pain. So this is the diagnosis of esophageal pain, gastroesophageal reflux syndrome, GERD. This is the diagnosis. Example number 7, the condition started gradually over the preceding 2 days. Chest pain that is variable in the location but often below the left breast and along the costal cartilage, variable in the time from few minutes to 1 hour, stabbing in the nature, not radiating, mild to moderate. These are the symptoms. Kindly note down. These are the symptoms of the musculoskeletal chest pain when there is movement aggravated by the movement of the chest, trunk, and the arm, and relieved by the medication. First we have chest pain, next we have a dyspnea and the shortness of the breath. In case of dyspnea, we will discuss the onset, duration, time of the shortness of the breath, its course, severity, you can see aggravating and the relieving factor, which factors cause decrease pain, which factor cause relieve the pain, which factor in aggravating increase the pain, and any kind of associated symptoms. Characteristics of dyspnea is: first, we have bronchial asthma, exertional or at rest, or the paroxysmal nocturnal associated with cough or wheeze, precipitated by the allergen, relieved by the bronchodilator. So, this is for the bronchial asthma. Nocturnal mean when there is symptoms at the night. COPD, chronic bronchitis, and emphysema, exertion or at rest associated with wheezing and cough. Patient sleep well by the dyspnea become worse in the on awaking in the morning. Next characteristics of the dyspnea are pneumothorax. In case of pneumothorax, patients suffer with the dyspnea. Sudden onset associated with the unilateral pleuritic pain. Pulmonary embolism or in case of infarction, patient also complain of dyspnea. Pleural effusion, gradual onset, worse on laying on the normal side. Left ventricular failure in case of rest or during the exertion when laying flat, or the proximal nocturnal dyspnea means at rest. Left ventricular failure also cause Shortness of breath. Pure mitral stenosis, it's similar to the left ventricular failure. Metabolic acidosis, in which there is pH less than 7.35. Other causes: Guillain-Barré syndrome, obesity, scoliosis. These musculoskeletal conditions also leads to the shortness of breath. Next we have acute dyspnea versus chronic dyspnea. First we have a cardiovascular causes. In cardiovascular conditions, acute pulmonary edema, this is the included in the acute dyspnea. And the chronic dyspnea, we have chronic heart failure. If there is chronic heart failure, it can cause chronic dyspnea. And the respiratory, you can see COPD, pneumothorax, pneumonia, pulmonary embolism can cause acute dyspnea. And the chronic asthma, chronic pulmonary thromboembolism, intestinal lung disease, carcinoma of the lungs, this can cause chronic dyspnea. In the metabolic acidosis, diabetic ketoacidosis, uremia, lactic acidosis, this can cause acute dyspnea. While this, in case of severe anemia, it can cause chronic dyspnea. Psychogenic factors: hyperventilation can cause acute dyspnea, and the some other causes. Obesity also leads to the dyspnea. In this we have also examples. In the example number 1, the condition starts suddenly 2 hours after sleeping at night as shortness of the breath that woke the patient from sleep was too severe, rendering him to stand up and open the windows in attempt to get air. The condition was associated with the productive cough of frothy pink sputum. His condition has been slightly improved by standing and use of oxygenation, whereas he asked for the help and immediately rushed into the emergency unit of the nearest hospital. The first line attack was managed in the hospital, and the second by sitting and the medication. This is the case of acute dyspnea with pulmonary edema. Example, and the nocturnal dyspnea, it's at the night. Example number 2, the condition started instantaneously and the shortness of the breath 1 hour after playing basketball. The attack was severe, made him unable to continue playing. A little bit improved with rest or sitting. Associated with the anterior chest pain. When asked his friend to be evacuated to the emergency unit, this attack was the second attack in patient life. The first has been 1 year ago while the patient was playing also and managed in the emergency unit. So this is the diagnosis with acute dyspnea due to pneumothorax in patient with Marfan syndrome. The patient was basketball player as he was tall, hence it Marfan syndrome, because in the Marfan syndrome it has a relation with the connective tissue formation. Next we have example number 3. The condition started gradually at the exertional shortness of the breath that was experienced after walking about 500 meters in the early days of illness. His condition worse after a few months, and shortness of the breath has been noted with the little degree of exertion, such as walking for 300 meters. 1 year after that, he started to become shortness of the breath, but activities like slow eating or walking or talking slowly or resting did not result in breathlessness. His shortness of the breath has been constantly of severity in the last days, was mainly worse in the morning or on walking, slightly improved with in case of inhalers, oxygen, and after coughing up sputum associated with the small volume productive cough and wheezing. The patient had noticed 3 separated attacks of severe breathlessness in the last year that was experienced even at the rest and necessitating hospital admission. This is the diagnosis of chronic dyspnea due to chronic obstructive pulmonary disease, and the COPD it include chronic bronchitis and emphysema. Next we have palpitation. Next, in case of palpitation, we will ask the patient about the onset and the regularity, if any kind of irregularity, specific description and feeling, speed and fast and slow, frequency of the attack, duration of the each attack, severity, any aggravating factors that can cause palpitations such as exercise, alcohol use of coffee, cola, any kind of drug, and the relieving factors, breath holding, exercise, Valsalva maneuver, associated symptoms we will ask from the patient such as with the palpitation, any kind of chest pain, shortness of the breath, polyuria, syncope. Okay, these are the things we can ask from the patient. We can ask the past history of valvular heart disease or thyrotoxicosis. It means increase the thyroid hormone, some causes, and the patient description of palpitation. In case of sinus arrhythmia, patient description is heavy regular beats that speed up and die down as when running upstairs, are noticed at the time of stress or anxiety. In case of extra systoles are ectopic beat. What is ectopic beat? In which there is premature beat present or there is missing in beat. Sinus tachycardia, this is the condition that comes and go on its own. In case of ectopic beat, heartbeat become irregular and there is any missing or skipped in the beat or jumping into a throat. This caused because the ectopic beat produced as a small stroke volume. So this is the patient description, and there is the missing of a beat. Next we have a proximal tachycardia, in which there is heartbeat is irregular and too fast. Next, in case of palpitation, we have examples. Example number 1, the condition repeatedly start gradually over few minutes as unexpected awareness of heartbeat that were regular, so fast and unrelated to the specific position. Each time the attack lasts for 20 minutes and disappear in the spontaneous manner. The attack was repeatedly recalled once the student awakened for exam and disappear after 10 minutes once she engaged into the exam. These are also a sign of palpitation. The student had noticed no increase in the urine volume during the attack, and each attack was not followed by faintness. This is the diagnosis of sinus tachycardia. Next, this is the example of ectopic beat, in which there is the patient repeatedly occur at the rest or went to bed, and unexpected awareness of the heartbeat that is infrequent and irregular. The patient felt missed the beat what it was doing but was followed by the particularly strong heartbeat. The attack occurred repeatedly but infrequently and disappeared when the patient started to walk or to exercise, and it was not followed by faintness and no urine volume increase. This patient lastly was heavy cola, tea and coffee consumed. So this is the diagnosis of ectopic beats. Next we have a diagnosis of supraventricular tachycardia, in which there is unexpected awareness of the heartbeat that was regular and unrelated to the specific position. The attack lasts for 20 minutes and disappears suddenly when patient used to introduce his right index finger into his mouth in a way of induction of vomiting. There is increase in the urine volume during the attack and are associated with the breathlessness but no loss of consciousness. This is the diagnosis of SVT, supraventricular tachycardia. Next we have a diagnosis of arterial fibrillation. These symptoms leads to this diagnosis. The condition started as unexpected awareness of the heartbeat that is irregular so fast and is described as a heart is jumping and persisting up to the time of history taking, and there is a sense of breathlessness and fatigue, and this is the patient is a consumer of a cola, tea and coffee. It is a diagnosis of AF, arterial fibrillation, when there is heartbeat is increased. The condition started as a unexpected awareness of the heartbeat that was regular. The attack was described that the patient heart is fluttering too fast, persisting for 5 minutes, and accompanied by sense breathlessness till he lost his consciousness. This is the diagnosis of ventricular tachycardia. When there is ventricular tachycardia means heartbeat more than normal. Next we have a syncope. It means fatigue or dizziness. In case of syncope, we ask the patient about the frequency, duration also, and first we will discuss the what is pre-syncope, syncope and the coma. What is the difference in them? Pre-syncope is the feeling of impending loss of consciousness. Syncope is the condition when there is sudden transient means temporary loss of consciousness but without featuring epileptic fits, and the coma is the persistent loss of consciousness, and syncope is the transient loss of consciousness. These are its differences. Ask the patient about the preceded by pre-syncope period, any kind of syncopal period, any kind of palpitation, emotional stress, frequency of the attack and the duration of the each attack. These are the things asked from the patient. And the dose certain position, if the syncope at the straining, coughing and the micturition, it occurred during straining, coughing or micturition. Any kind of associated symptoms. What are the symptoms that follow this syncope? These are the questions we will discuss. Ask the patient about the drug history. Drugs also called faintness. Common causes of a syncope. These are the cardiac and non-cardiac causes. Now I will just tell you the diagnosis of a disease and you read this according to the patient symptoms. These is become the diagnosis. This case is probably hypertrophic cardiomyopathy. You can read this and easily go through it. It's very easy. I will tell you before and you can read it as. So I will tell you about the concepts only in the example number 2. Read this and do this. Such a presentation would raise suspicion of vasovagal syncope. It is the case of vasovagal syncope. In the vasovagal syncope, there is heart rate and blood pressure become decreased. You can remember this and read this once. Next we have ankle swelling. In case of ankle swelling or body swelling in the general, ask the patient about the site, if there is localized swelling or generalized, what is its onset, duration, if it's of 20 minutes, 30 minutes or 1 day, 2 day means duration, and the progression, if there is mild, moderate, severe, what is its character, painful, painless, and the severity, aggravating factor and the relieving factor, which things can cause decrease in the edema, which cause increase in the edema, any kind of associated symptoms. If there is jaundice, then everyone know this is the hepatic cause. So in case of ankle swelling, ask this from the patients. Local tenderness and the warmth, it is the suggestion of inflammation. Local cyanosis, it can we can go through from venous obstruction. This is the suggestion in individual who had repeated episode of prolonged edema. Skin over the involved area is thick and often red. Causes of localized edema, you can read this. There is a traumatic inflammation, lymphatic, venous causes, metabolic, cellulitis, brachial cyst. This can cause edema, and immobility also cause edema. Cardiovascular causes, renal, allergic, hepatic, nutritional, endocrine, hormonal causes, lymphatic obstruction, immobility, pregnancy. These can cause edema. Generalized edema, fluid overload or hypoproteinemia. It means protein is decreased. Fluid overtake, hypoproteinemia. This you can see. Next we have examples. This is the diagnosis is generalized edema due to hypoalbuminemia. This is the case you can study, and these are the symptoms. These lead to this diagnosis. Next we have example number 2. It is the generalized edema due to the fluid overload, for example in case of cardiac failure. Next, the example number 3. It is the localized edema due to the deep venous thrombosis. In case of deep venous thrombosis, the deep vein in the legs, there is a clot formation in the deep vein in the legs, and this is the thrombosis. And if the clot travels to the heart and cardiovascular system and the cardiopulmonary system, this can cause embolism, and it can cause deep venous thrombosis, and it leads to the death of a person. Example number 4. It is the localized edema, lymphoedema due to the lymphatic obstruction. Due to the lymphatic obstruction, fluid accumulate and it can cause edema. Next we have example number 5. You can read these are the symptoms, and this is the diagnosis of localized edema due to the cellulitis. Cellulitis means inflammation of cell. Intermittent claudication, it's of neurovascular causes. In this case we can ask the patient about the site, onset, timing, factor, activating, relieving factor, associated symptoms. All these things are the same. We can read from the chest pain, syncope, palpitation. All these things are same. This you can see, it is very important clinical features of a arterial neuropathic, neurogenic and venous claudication. This you can read it very easy. Pathology, site of pain, laterality, onset of the pain, relieving, color. These you can see very easy. This you can read and note in your notepad. Next we have example number 1 of intermittent claudication. This is the example of arterial intermittent claudication due to the left femoropopliteal circulation ischemia. Ischemia, when there is blood supply is reduced. Second example is the arterial intermittent claudication due to the aortic iliac circulation ischemia. Example number 3. This is the diagnosis of neurogenic intermittent claudication. These are the symptoms you can read, and it leads to this diagnosis. Example number 4. It is the diagnosis of venous intermittent claudication, and it is the diagnosis of rest and in case of night arterial ischemic pain. And this is the lecture of the cardiovascular system, in which we discuss the 6 things, okay, and their case discussions. First I explain the cases, and now it's not important to read these things. You can read it, note down the symptoms, and below this write the diagnosis of each disease. Thank you so much. Next we will discuss the respiratory system.